They may or may not. I don't know.
Did they have a good turnout?
They had about 15 people, including some people from Australia and I think South Africa.
Oh, excellent. Did you moderate that one? No, I
No,
guess not.
no. Just listened in. And they had a doc from Hopkins, I think, who was pretty active, who's been very active, who spoke to them. It was, I think they were pretty happy with it. So, and they're
Very good.
doing another one, and then they'll do another one. I've offered them some slots, but they haven't grabbed one yet, and those slots are going quick now. So,
Great.
what can
We're
I
gonna have
say?
more meetings in time pretty soon here.
Yeah, I know. We'll have to add. So anyway, so Peter is not here. So we have one person on the phone so far. Who is that?
Dennis,
Hello, I've been wanting to call you just to wish you a happy holiday. How are you?
Hi,
hello.
Dennis.
Hey,
How how are you?
I'm doing just fine.
Good.
How are you?
Yes, I'm fine, but I'm cold.
Uh-oh. Did you run out of firewood down there for your...
Yeah. I had my fire going last night, Dennis. I did.
Good.
I did.
Well,
But
you gotta make like a reptile over here in the Southwest. You know, when the sun shines in the afternoon, it's nice and warm. You go sit out there in the sun and let your body heat up, and then you go in the house and put your sweaters on.
I know. I just came back from a bike ride. I waited until it got as sunny as it's going to get today, and so. But you're absolutely right. When that sun comes out, you got to grab it, right?
That's right.
Okay, so it looks like we got a small turnout today. I don't know where everybody is. I am actually thinking about maybe advertising the group on Inspire in the new year. Um, I feel like we could do that now because
I
the
think
month
that'd be a
we're
good
getting.
idea.
What's that,
I
Jake?
think that would be a good idea.
Yeah,
I saw some comments on Spire the other day about people their local groups have have faded away for whatever reason,
yeah,
lack of funding or whatever. And so it'd be a good opportunity to say, well, hey, we got an online call that you could join.
yeah. I think I will. I think I will start to do that. I see on the call right now, uh, Jake, Larry Fish, George Savier, Dennis Correa, and that's it. Is that right? Did I miss anyone?
So far,
So far, so good. We'll see who comes in later on. Well, I want to welcome Dr. George because we have. I don't even know if you've ever been
Been
on.
a while. Yeah, I've been on the phone call, but I've never been on the webcam, the
Okay.
computer.
Well, it's an
So
awful.
this is pretty interesting.
Yeah, it's an awful long time since you've been on the phone call. So if I remember,
Yeah,
if I remember correctly, um, you connected with Dom, God rest his soul, through us too. Is that right?
yes, yes. That was
Um,
quite a while ago.
yeah, it is. And then you and Dom talked for a
Yeah, we
long
talked.
time.
Yeah, it was very nice chatting with him, and I need to do more of that. My situation now is I've gotten pretty heavy duty treatment, and the cancer is great. It's under control, but the treatment um, really has affected me, and physically, mentally, emotionally. Um, I guess that's the price I had to pay for getting aggressive treatment, which is what I wanted.
Right.
Uh,
So
and I finally got Dr. Myers.
why don't you just give the guys on the call a quick update? I mean, I know a little bit, but give them a quick update on your background, age, your diagnosis, and everything else, and then let's talk about how we can help you and maybe suggest some ways that might mitigate some of these side effects.
Okay. I am a 54-year-old emergency room physician from Rhode Island. And I was diagnosed when I was 51, so about three and a half years ago. I had numbness and weakness in both my legs, and I started having some low back pain. And I had never had a PSA, so this was after a bilateral hernia surgery. So I thought it was related to that, and I finally asked my surgeon to get a CAT scan, and he did, and there were multiple bony lesions, the pelvic bones, the femur, and then followed by an MRI, which showed a spinal cord compression at L3. So my treatment consisted of Taxotere right up front, along with Firmagon and Xtandi, as well as a few other things, Avodart, Metformin, estradiol patch. And my PSA dropped rapidly, and all my lesions cleared up. I had emergent surgery when I first had the spinal cord compression, and I had a fusion. However, the fusion did not take because of all the treatments I had. So I had to have another fusion done in this past July. So I am fused from T11 to the sacrum. So the surgery was 4 or 5 months now. And I'm feeling better in my back physically. And I was seeing Dr. Myers, and he left. I guess he retired. So I had to find a new doctor, and that was tough. I basically went with who he referred me to, and that was Dr. Farina at Rabbit Woods Johnson, Rutgers Cancer Center, and I went to see her. So currently, I just had a prostate biopsy. Dr. Kim over there, there's a couple of studies that are, talking about radiating the prostate or doing a prostatectomy on people with metastatic disease. And since I had de novo metastatic disease right up front, my prostate is still my prostate. Mm-hmm. And the biopsy, which she thought was going to be positive, was totally negative. 14 SNPs are all negative in my prostate, so they decided that wasn't probably, just leave the prostate alone, which I'm fine with that. And my scans and my CAT scans and my bone scans have been negative, and my PSA up until the biopsy had been pretty much undetectable, ranging from 0.01 to 0.1, fluctuating. So, my last PSA was 0.12, which, is up from 0.03. And they said it was probably from the biopsy. So I'm waiting for my next PSA to see. I'm one of those people that get very anxious when I get my PSA done. So, I'm currently, a lot of side effects from the surgery and the treatments. My testosterone's almost 400, 500. But the actual free testosterone is still low, so I'm still having side effects from the ADT, and I've been off it for about a year now. So the only meds I'm on now are metformin, Avodart, estradiol patch. I'm not on any hormonal therapy right now, and like I said, my bone scans have been negative. My PSA has been very low, and it's been 3.5 years. So I should be very excited about that, and I am, because I had a very high burden of bony mets when I first got diagnosed. But I've been having severe depression. Feeling isolated. I mean, I wish there was a guy, and if anybody knows of a guy with my story, let me know. I want to talk to him, because I'm not the typical presentation, and I've been told that by many doctors that I've seen. So, right now, like I said, I'm just dealing with a lot of depression. Could be holidays, as far as intimacy with my wife, it's been a problem, for 3 years, and that's a lot of stress on my wife and myself. But and I've tried everything. I've tried all the different. I've tried the shots. The only thing now is an implant, and I'm kind of waiting on that. I want to see if my testosterone recovers. But it's tough talking about that. But I do go to some support groups. There's one in, I live in Rhode Island, so I go to one at Sturdy Hospital in Attleboro, and I sometimes go to the one in Boston, which is on the first Monday of every month. Mm-hmm. And Stanley Klein does that one. I like that group because there's a lot of men with advanced prostate cancer, and it's a very good discussion. The only problem is I'm so tired all the time. I gotta say, it always comes up, and the Monday comes, and I just don't feel like getting up. So I still suffer with a lot of that, fatigue, exhaustion. So that's kind of where I'm at. I kind of realize now I need the support of other men. Mm-hmm. Because this is a very isolating disease in many ways.
Well, I am actually, I've got a few technical suggestions I want to address, but I'm going to let Jake respond to you first, because he's probably thinking the same thing I'm thinking. Go ahead, Jake.
Okay. Hi, George.
Hi, Jake.
I'm Jake. On every second and fourth Thursday, we hold a meeting on same number, same line, everything. 8 o'clock, second and fourth Thursday of the month. It's called Inner Conversations, and Rick is the man that can talk to you about technical stuff, the medicines and all that. But we talk about the emotional stuff. How is this making us feel? Are we depressed? Are we sad? Are we mad? Are we all the above? And we don't always. We're not psychiatrists. We're not doctors, so we can't really solve any problems. But a lot of times we just, we kid around. We tell jokes, and once we get to know you, we won't give you any slack. We'll just, it's basically a bunch of guys sitting around BSing a lot of times, and we have a good time. And by the time it's over, we usually end up feeling good because we're all in it together. Like as you said, it can be a lonely disease. It can get depressing. But the guys most of the guys have had have been through similar things and still are going through similar things. So I'd love you to join us. The next meeting is this Thursday, 8 o'clock. Okay, please join us.
Yeah, I get the emails, so I get the reminders, which is good. So I just have to look at the email and
Yeah. Well, stop ignoring the emails. Pay attention to them and join us.
Okay.
You know, you're going to find on that group. I mean, I have attend it very rarely, but I think you're going to find a couple of men that have somewhat not identical, but somewhat similar situations to you. You know, in the sense that they're younger, that there are some that are younger. They've been diagnosed with metastatic disease. The metastatic disease is somewhat under control. Um, you know, Jake's relatively close. Jake, you did have primary treatment. Yours is recurrent, but you're also younger, and your disease is currently under control, right? Correct?
Right. So far, yeah. Even though I had stage 4, you know, it's mine's not curable. I also have it in my bones, you know, my sacrum, my iliac wings, my hip, my several spots on my spine. So I get quarterly shots of Lupron, which is similar to the Firmagon that you got, but you were getting that once a month. Lupron's
Right.
quarterly, and I also get a bone treatment, and I'm also taking Xtandi. But like Rick says, I'm currently under control. I just had a blood test on Thursday, and I haven't gotten it yet because of the Christmas holidays. I'm hoping it stays the same. We have another guy. We have several. You know, I had to warn you. Everybody has different stages on this call. You know, we have one guy, we call him Eeyore, because he tends to get very depressed. He says, "Oh, I'm at the end of the rope," blah blah blah, and we try to cheer him up, and we usually do. You know, he says, "I love you guys. I feel better now." So, but yeah, Rick says, there's other people who you know, have had it and are have it under control. You know, your cancer was never real serious. It doesn't sound like. I mean, all cancer is serious. I don't mean that, but yours was never probably not that far advanced, other than the Mets. You know, and I guess they told you that they can't get rid of the Mets completely, even though yours are out or gone for the moment. Once it's in your bones, it's usually not. It's usually going to come back at some time, some point.
Yeah. Yeah.
But you said your testosterone is about 500.
Yeah, 400 to 500, but the free testosterone is very low.
Wow.
So I'm essentially still castrate, but it's coming up slowly.
Right. Well, it takes a while for the Firmagon to wear off. You know, I know with Lupron it takes, you know, some people up to a year and a half, sometimes longer. And the older you get, the slower it's going to respond. But it sounds like yours is coming back, so that's a good sign.
Yeah, I was on it for 2 years
Yeah.
with
So.
the Xtandi.
And you said you had the Taxotere, but you're not on that anymore, right?
No, I got the Taxotere right up front. It was actually just after the Charted trial came out, so
Right.
I got the Taxotere right away. I did have a lot of bone marrow suppression. My T cells dropped, so I was put on Leucine, and that really helped the T cells come back up. However, my new doctor told me to just stop it, and that's I'm a little nervous about that. But you know, you know, one thing I've always done, and I'm a doctor, so you know, I tend to want to treat myself. But
right.
The one thing I've done correctly with this cancer is I do what the doctor tells me to do, and you know, I mean, if I don't agree with it, I'll say something. But you know, I was looking for aggressive treatment. I went to 3 very, very, very good hospital centers in Boston, and I just heard the same thing from every hospital. We'll give you the shot, and we'll see how it goes. And then when your PSA starts going up, we'll do something else. And that's not what I was looking for. You know, you're 51. You know, you don't want to think about you know, dying in 5 years.
You're right. I don't think, George.
There's always the number they give you. You know, I don't know. I know it's not 5 years, but
I don't think you'd
It's
hear
very
that today, interestingly enough. I mean, I think that maybe 3 years ago it would have been it was clearly more of a struggle to get more aggressive treatment like chemotherapy up front. I think today every pretty much every decent genitourinary med onc out there is either going to offer you chemotherapy or a second line anti-androgen
Right.
together with the LHRH drug.
Mhm.
So I mean, things have really changed a lot. Um, and the it's interesting because with the chemo um, because Snuffy was never a huge fan of chemo. Um, so did he offer that to you early on, or was that a discussion, or did you between the two of you come to an agreement that it would work for you?
Yeah. Actually, I was treated locally by a local medical oncologist, so I got the treatment there.
Hmm.
And then I decided that I really needed to find somebody that specializes in prostate cancer.
Hmm. Hmm.
So that's when I found Dr. Myers,
And
and
who prescribed the chemo?
my local medical oncologist, Dr. Nadeem. He runs the uh, Landmark Medical Center,
Right.
Cancer Center.
I mean, that was really visionary back in 2014. Um,
Yeah, yeah.
and as you know, Dom, God rest his soul, got early chemo because he was in a trial. Um, Personally, I mean, we don't know, but personally, I do think that it made a big difference in how long he survived um, because he lasted 11 years after that.
Mm.
And, we don't know. Uh, we can't prove that that was what it was, but what we do know now is that the chemotherapy seems to have the biggest bang for your buck if it's used early in men that have metastatic disease. Depending on the studies, anywhere from 14 to 22 months is what the increase in overall survival showed. So so the chemotherapy is really a great option, and there were docs that were willing to prescribe it 3 or 4 years ago, based on the charted results. But since then, with more studies, it's pretty much standard that they will offer you one or the other. And I would encourage you to listen to the conversation um, that is bookmarked on our webpage.
Oh, is
Uh,
that with Dr. Morgan, Dr. Ryan?
yes, did you listen
Yeah,
to
I
it?
did listen. I did listen to that. It was a very good talk.
Wasn't it? I thought so. I thought it was great. And there's others, by the way. There's a good. I didn't link it. I've got it, and I can send it to you. But there's a really good discussion just uh, between Morgans and Ryan. And then there's a good piece by Morgans that she wrote. Um, but that's really where the thinking is today. Which one shall we go with? And if a patient is resistant to chemo, then don't fight them. Just give them a second line anti-androgen. If not, maybe the chemo. But I think that was a great treatment for you. I think what's really interesting in your case is that you are now taking a break. And I texted Len just before, Len Sierra, um, and but I haven't heard back from him. He said he was going to be on the call because Len was diagnosed with lymphatic involvement, not with not with bone mets, but he's done a bunch of treatment, no chemo, but he has done several holidays. So I
Mm.
was hoping that he would talk to you a little bit about the holidays. Um,
Yeah, that's so. That's I don't know. I think people are I think people are coming around with that, but there's still a lot of doctors that just say, you just have to stay on this forever. However long that
Right.
is.
So I want to bring in both Dennis and Larry momentarily because I think both of them have got experience that's probably relative to your situation. But I made a couple of notes as you were talking. Are you taking a statin?
Yeah, I'm taking Livalo, um, and I'm taking phenofibrate.
Okay. I thought Snuffy loved rosuvastatin. How come you didn't go on that one?
Well, I've had statins in the past, and I've always had rises in my CK and my liver enzymes.
Yeah.
So far, this has been I haven't really had any muscle soreness, or
Great. Okay.
my liver function tests have been great too. So far so good.
Okay. So I'm going to just add that to my notes. And then what about an antidepressant? Are you using one?
Yeah, I've been taking Wellbutrin for I've had depression prior to the cancer. So like you mentioned in one of the other talks, I wasn't shocked by the worsening of the depression.
Right.
Um, and I did have a lot of those angry outbursts that people have talked about when I was on the ADT. But the Wellbutrin seems to be the only one that works, so I've been on that. And that seems to be the only one I respond to. I've tried many others,
Hmm.
so I'm on a fairly high dose of Wellbutrin.
Okay. Have you tried? I mean, because you're still wrestling with significant depression, have you tried increasing the dose when you get hit with a bout of depression?
Well, the maximum it's 300 is the standard. The maximum they recommend is 450, and I'm at 400. So, I mean, as you go higher, the risk of seizures go up. So I'm hesitant to do that right now, but
Hmm.
I think if it gets worse, I'll talk to my psychiatrist
Well, I
and
was
see what
just
we
gonna.
can do.
That's exactly what I was gonna suggest. That there are so many good drugs and new drugs that are out there, and if they know that the Wellbutrin works well for you, I can't remember. Is Wellbutrin an SNRI?
It affects serotonin as well as dopamine,
Right.
so it acts a little differently than all the other SSRIs and SNRIs. So it's in a category of its own. It's what
So,
they give for smoking, to
so
quit smoking.
So I heard something really interesting a couple of weeks ago that I want to look into for myself personally. I mean, you probably have heard from listening to the talks that I come from a significant family history of depression, and so I've tried over the years. I mean, it goes back even to when I was a kid. There were issues, but I've been actually medicated on an SNRI now since 2000, and I have a really close friend here who's a family physician, and he happens to be going out with a psychiatrist who I've become friendly with. She's great. She's a really good woman, and she was telling me that for people that respond to an SNRI or similar, um, they found that about 70% of that population have a genetic mutation, and that I don't exactly understand it. You may understand it better, but it has something to do with, I think, a laziness in producing folic acid. I think it's a laziness. It could be hyper. It could be too much.
Mm.
Um, and that they now have a drug that they use that corrects that mutation, and which a lot of people on SNRIs respond to and makes them feel a heck of a lot better. So I actually plan sometime this early in the year, I'm going to try and make an appointment with a psychiatrist. I can, on my health plan, I can self-refer, and Dawn doesn't want to see me because we're friends.
Yeah.
And also she doesn't take my insurance. But I'm going to go and discuss it with them. But you might want to just raise that with your psychiatrist and see if that's a situation that applies to you. It's a simple genetic test, and it's and there's a simple, inexpensive drug that will help.
Yeah, no, I'll talk to him about it. Like I said, I've been on all the past ones. They've actually worsened my depression. Okay. So I just don't tolerate it. Even so I tried Cymbalta for I have a lot of neuropathy from the spinal cord, but
right.
I take gabapentin for that. But I tried Cymbalta, that didn't help.
Did the gabapentin help you with the neuropathy?
Actually, it did. But I had to take a high dose, but it did help. Yeah, but it does increase your appetite. I mean, and the last thing I need is to put on any weight.
No, I ask because I'm wrestling right now. As soon as the weather gets cold, I wrestle with neuropathy. It is a side effect of the LHRH. It's not that common, but it is a side effect, and it comes every time. I get it just in my feet, in my heels, and my toes, and but the last thing before I open it up is intimacy. There's a couple of people that it might be good for you to speak with. There's a guy that we met at the PCRI conference, a couple actually. Michael, I forget his last name, but I have it, and I will send it to you afterwards. And
okay.
and he runs online meetings, and he's available to consult, and you might want to reach out to him. I was quite impressed with him.
Okay, yeah, sure.
That's one possibility, and then start with that, and then I've got another couple of people that we've worked with here on intimacy issues that are available and maybe good to talk to. But I will I'll send you, and then if you like what you see, let me know, and then I'll send you I'll do an introduction to you and to him, so that you don't.
Okay. Yeah. Yeah, that would be great.
Yeah. So I will send that to you after the call. So let me open it up to both Larry and to Dennis, because I feel like they may have some contribution to make to your situation, and some thoughts how they could improve. You could improve your situation. Larry, do you want to kick off?
Yeah, sure. Can you hear me?
Yep.
Is it coming through?
Yeah.
Got me?
Yep.
Okay, good. So, I had a couple of thoughts, but I had a question. Did you do an original biopsy when you were first diagnosed?
Yeah, they did a biopsy of the bone, the spine.
And did they give you a Gleason score?
Yeah, it was 8.
It was 8. Yeah, same for me.
Yeah.
It's so interesting. You started with Taxotere, Firmagon, and Xtandi right off the bat, and estrogen.
No, I actually started with Casodex and
yeah.
the Taxotere and the Degaralex.
Oh yeah.
So I was on all 3, and then when I went to see Dr. Myers, he switched me to Xtandi, which took a few weeks to get because the insurance didn't want to pay for it. They said it was $8,000 a month.
Yeah.
Oh,
I hear that.
I wrestled with them. I got it approved, and then my PSA it really dropped pretty rapidly, and I was very impressed with that.
So one of the things, we were diagnosed more or less around the same time, and I also had I had a PSA of, I forget, 500. 7,000, whatever, some extraordinary number. And I had went to the they were just talking about the studies, the two studies, the Charted and the other one. I would say Stackhouse, but it's not Stackhouse. And I went to Brigham Young to see Dr. Kessler, I guess, there in Boston, and he said, "Oh yeah, these studies are just coming out. We should get you going on Taxotere, docetaxel, and it might be a benefit." And what I went back and looked at a lot of the charts in the cancer.org, there's the survival statistics, where my original oncologist had said, oh, probably maximum 5 years, more likely 3 years, since it's already, and throughout your bone scan, it's a Christmas tree, that whole business. Yep. And then I realized that those statistics are based on data that is, not in the last 5 years. It's in the 5 years before that. And that they didn't really have the kinds of statistics that take place when people are going, serious statistics, when large numbers of people are starting with chemo, or people who go to Xtandi go to abiraterone or enzalutamide as a second stage. They didn't have the information about Provenge that people might consider, and there's all this stuff we're reading about now, all of these immunotherapies and personalized medicine, and based on the genetic testing is getting more accurate, and the somatic testing, if you could think about. So there's a lot of hope down the line. There are also working with the different bacteria, the virus there, the different combinations to recharge your immune system. Even people talk about like fasting plus something to recharge your immune system. I know Listeria probably failed, but there are other ones going on. So there's a lot of hope. And when I see my oncologist at Sloan now, and I say, well, now it's 3 years, what does it look like? And she says, well, it doesn't look like you're dying at the moment. So she's got to say, well, let's see how it is another 3 years, or I don't know if it's 5 or more, but I'm going to be 70. And I said, but there is hope also. And she said, yes, there really is hope. So that's quite different than those kind of statistics that they had when we looked at them first 3 years ago. Those were based. So that was pretty encouraging for me. And do you try exercise as a treatment?
Yeah, it's been tough because of my back. I mean, the 2 back surgeries really put a damper on that. But I was going to the gym and doing the bike, doing some treadmill, walking with my wife. I used to run marathons. I mean, when I was healthy 10 years ago, I used to run marathons. I've probably done 20, 25 marathons. Wow. So that was a big deal when I got diagnosed. I haven't run in 3 years. And so it's been tough. But my wife runs now. She does 5Ks. So
that makes you feel better. One idea, do you think about taking swimming lessons and trying to do in the water? It's much better on your back. I went and took a series of swimming lessons. You start to build up. It's pretty cool, and then you get in a good mood.
Yeah, that's what my physical therapist told me. Get in the water. Do some running in the water.
Yeah, you could just I find that you can even walk fast or try to run up and down the side of the pool, up again in the lane. You can run most of the way, and then you can dog paddle or whatever you can do the rest and come back and run again. If you do that for 30 minutes, an hour, you build up, you burn a lot, and your mood gets better. I believe that's really true. I think that they have evidence proving this as well. Then there are other things along exercise. There are things like the Feldenkrais movement, or these kind of, like movement processes, not really yoga. So it's kind of like a somatic therapy kind of stuff. And I find this helped my tremendous depression because I'm on permanent Lupron. I'm scared to take a holiday so far.
Yeah.
So that's just what I wanted to say. And then, did you think about doing somatic testing, or there's nothing to test right now? They didn't.
Well, you're talking about pathology and the genetic testing.
Yeah, well, there's the genetic testing, and just to see if there's some, as Richard would say, actionable, mutation or defect.
Yeah, I did. They did Dr. Myers did the genetic testing, and I have a whole profile of mutations. So I did have that done. There's about 5 pages. I don't have the BRCA gene. It's androgen, positive. So it's sensitive to all the medications I was taking. So he covered everything. Yeah.
So that's really all I really had to clarify or to say is that I find myself able to get in better moods by I'm doing Headspace, some kind of application app for little 10-minute meditation, and I use the elliptical or go swimming. Mm-hmm. And if I can do that 3-5 times a week, I noticed over the time it helped deal with that terrible feeling of sexual impotence and Lupron and ADT and the depression of like, whoa, what happened to your life? Yeah. So that's my main suggestion, my main comment.
Yeah, thanks, Larry. I mean,
thank you very much.
I think there's some really good information in there, and I can't endorse enough the impact that if you yourself. I mean, if you get that heart rate up, I mean, you know it well enough from doing as many marathons as you've done. One piece of equipment that you might look at is the reclining bike, because then your back is well supported, and you can get a pretty good workout on that reclining bike. Because I've actually been using one recently for the last couple of months, and I'm really pleasantly surprised with how good workout I can get out of it. So I would strongly recommend that. One other thing that I wanted to mention to you is that one of our, in the past, quite regular, more recently less regular participants is a retired doc. And they biopsied him after docetaxel, and he too was negative. He was diagnosed like you with metastasized disease and a PSA of 1,000, and he responded quite well. But when they came to biopsy him about 18 months later, there was no disease in his prostate. They still decided to debulk with radiation, not with surgery, and they only debulked. They didn't do pelvic girdle radiation. Another guy who I think I'd like to put you in touch with, who is not a doc, lives in Phoenix, 54 diagnosis, diagnosed with significant metastasized disease, and he's also brought it pretty much under control. And in his case, they debulked with and they gave him pelvic girdle radiation, both with IMRT. And he's doing quite well right now, Ken Anderson, and maybe you should chat with him a little bit. I want to go to Dennis, but I just want to acknowledge that Len's now with us, because I wanted Len to talk to you a little bit about his drug holidays. But Dennis, what do you what suggestions might you have for George?
Yeah, well, first off, George, I'm Dennis Correa, and I'm a Rhode Island native. Don't live there anymore, but I'm retired in Arizona.
You know where Cumberland is.
But and similar to you, I was diagnosed metastatic just a couple of years ago, but not quite, not your age. I'm about 20 years older than you are.
Mm-hmm.
So I think that's a major difference. But I had started off with docetaxel, Firmagon, and graduated to Lupron after, and then had Recurrent, and now on Zytiga for about 3 months, and had excellent results. My PSA is back down again to a 0.3. So that's kind of where I'm at relative to your situation. But one of the things I didn't hear anybody mention was a DEXA scan or bone scan, whether you've had that done.
Yes, I did, and it was fine. And I also had what is that, Xgeva?
Mm-hmm.
Yeah,
Yeah,
Xgeva.
I had that initially too for about a year. Yes.
Yeah, with spinal cord compression, from what little bit I know about it, because when I went out for my second opinion after my initial diagnosis, because I have 5 Mets in the lumbar, the doc had told me I told her I was playing golf, and she had advised me to not play golf because
Really?
of the risk of spinal cord compression.
Yeah.
And after I went back and I ended up with it, I didn't go to that location at the time, found another doc, another medical oncologist that I went to, and he had reviewed all my scans and everything else. He said, "No, you're okay. Play golf." He says, enjoy yourself. And so I said that, and I said the issue about the exercise you guys talked about, and all I can say is, I know the fatigue that comes, and boy, that's the time you probably need the exercise the most. And I do find that sometimes I gotta force myself. I said, boy, I'm really feeling exhausted. I need to go take a walk, and it's 10, 15 minutes at a time is probably about what I do, but I'm not an endurance person like you were with your marathons.
Well, I think I should take a flight to Phoenix, and then we can walk together. Because right now it's about 20 degrees and wind chill of 0. And
yeah, it was. I know, that's why I'm here. It's 75, I think, today here.
Oh,
and I'm in Tucson, actually.
Oh,
75 here in Tucson. The other thing is, I think, with your emotional state, I can sympathize with that, and I am on the Lupron every quarterly injections, including the Zytiga and prednisone.
Mm-hmm.
And I do have these periods that come on relatively quickly of emotional, and my eyes well up, and all of a sudden a couple of waterfalls coming out of my eyes here.
Yeah, I can identify with it.
Yeah. So I kind of learned the types of things that the stress type things that may be triggering these things, and immediately when I start feeling that way, I try to redirect my attention someplace else and get something else going
Keep
for
moving,
myself
right?
to avoid that. But not having a medical background or anything, that was about all I think I could contribute to what you're doing. I'd like the Zytiga for myself. It's and I think the understanding of knowing that this disease is permanent, and you're just going to have to keep treating it. That's the tough pill to swallow. And once you get through that, what my objective is now, my shorter term objectives are, keep taking, looking to see what's new out there, get the newest, the best stuff, and start it early. Is the other thing. I think there are some doctors out there that are tended to say, well, let's not start it yet. Matter of fact, I had a doctor like that. He said, you're doing fine. You're doing fine. You don't need anything. And then I said, well, I better go back to the first oncologist that I had up at Mayo Clinic in Phoenix, and did one of the latest scans for very specific for prostate cancer progression. And sure enough, they identified 3 new mets that I had. And so immediately that's when I started. Pardon?
Is that the new bone scan they have?
Yeah, the flucyclovine.
Bone scan?
Yeah.
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 All right.
Yeah.
Oxymin, yeah. So after that, then I saw that, and then we saw the results from the Zytiga Xtandi trials, and they took after the scan at the Mayo, they did a tumor board review of my status, situation, history, and everything else, and the tumor board came back with the Zytiga recommendation. So I just, it's that confidence level, number one, in the doc that you're seeing. You got to have that confidence level, and I did with where I was going at Mayo. And I think the other thing is I do get treated here locally, get my blood tests locally in Tucson. I don't even have to go to Phoenix. I was on a 3-week schedule when I started the Zytiga and the prednisone, and I did very good results-wise, and all my blood chemistry was looking really good. Everything was right within range. So they kind of gave me a holiday, at least from my blood testing. Anyways, that every 3 weeks he's gave me till the end of January now, so that's a couple of months.
That's great. Sounds like you got it all. You got a good plan. I'm a little nervous now that that I had to switch doctors. So right now I've only seen the doc once, and she comes highly recommended. So I'm gonna give it a shot, and if it works out, great. If it doesn't, I'm gonna find somebody else. But I mean, I understand the concept of being the captain of your ship.
I mean, the one guy that I think I would really that I like, and we know someone else who sees him that's in your area, is Sweeney. I think he's great. I don't think you could, if you wanted to consider somebody more local, I don't think you can go wrong with Sweeney.
He's in Boston, right?
Right. I think he's at Dana-Farber. He's a GU med onc at Dana-Farber.
Okay, I saw somebody else there. I didn't see him when I went. I saw somebody different. But
we've heard different. I mean, the 2 guys that I know that are good are him and Ellie Van Allen. But it's hard to get an appointment with Ellie Van Allen because he spends so much time in research. I think Sweeney does too. But I'm just impressed with Sweeney. I'm trying to think who it was that sees him. I could look it up. But I also like the way that he spoke on those on that conversation.
yeah.
So somebody has joined us on the telephone for a while. I'm sorry I didn't welcome you earlier. Who is it that's on the telephone?
The ugly guy, Jeff Ledoux.
Oh, Mr. Ledoux. Okay, welcome, Jeff.
Jawohl.
Welcome, Jeff Ledoux. Len, welcome to you too. Do you remember George? Do you remember Dom? Dom spent a lot of time working with George one-on-one. George came to him through us too.
I'm sorry, I don't remember that, but
Okay.
Nice to meet you, George.
Hi.
Don was also a very good friend of mine.
And George has metastatic disease, but he's been in the fortunate place of being on a LHRH vacation for how long? How long is it since you had? When did you last have your last LHRH shot?
It's been over a year.
Over a year.
No plans to go back on it either.
So I thought you might have some
None.
thoughts on that, Len.
None. 0.
Your PSA is 0?
It's been between 0.02 and 0.1 for the last year.
Wow,
But
fantastic.
I just got a biopsy, a prostate, the prostate biopsy, because there was consideration of doing a prostatectomy. And they did 14 bites, Dr. Kim at Rutgers, and it all came up negative. So they don't want to touch my prostate right now. But my PSA did go to 0.12. The last one was 0.12.
So what was your primary therapy?
I had spinal cord compression, so I had bony mets and a Gleason score of 8 and a PSA of 94 when I was diagnosed. So I had metastatic disease right off the bat, and it was everywhere. It was in my ribs, my pelvis, my femur, my spine, and my bone scans have been negative as well.
And this was brought about strictly by hormone therapy.
Yeah, I did the Taxotere, and then I did the
Taxotere.
Firmagon and Xtandi. Probably for 2 years. 2 years.
Wow, that is remarkable.
Mm-hmm.
I'm 9 months. I'm a Gleason 9. I had primary radiation therapy as well as hormone therapy, but this is my second round on drug holiday, and this one's lasted 9 months. And doc says you could probably go another 3 months, and we'll check again. My PSA is higher than yours, but he thinks it may have at least temporarily stabilized at 0.5 or plateaued at 0.5. It had steadily crept up from 0.1 to 0.5, but then the latest one remained at 0.5. So
how are you
how's your, I feel great. How's your T level? Did it come back? Did you recover?
Yeah, my total is up, but my free testosterone is still very low. So I'm still having a lot of symptoms of low T, which but I tell you, I take the chemo over the ADT any day of the week.
Really?
Yeah, it really knocked me down.
Okay.
Yeah, and I still feel not so great, but you know, I've got to do the other things. I got to do the diet and the exercise, and I mean, I've been taking the meds for quite a long time, and well, 3 years. I mean, it seems like a lifetime, but I'm slowly starting to feel better.
Tell him what your testosterone is, Len. Give him something to shoot for.
Mine did shoot up to 750, I think it was, from less than 4 back in April when I was on abiraterone.
And that was only after how many months off?
That was about 7 months, 6 or 7 months. It went up to 700, but even by 3 months, it was up over 300.
Oh wow!
And he's much older than you, George, too. He's, what are you, 68?
Yeah, that's right, Jake, 68. How old are you, George?
I'm 54.
Okay.
So you have hope, man.
Yeah.
Yeah.
Yeah, you'll get there. But I guess you were on ADT for a longer period consecutively than I was. That may have something to do with your slower recovery.
Yeah. I was told that, I mean, it might take a few years to really come back.
Yeah, but, and I'm sure the exercise will help get it back up as well.
Yeah. Well, that's great. Oh, that's pretty good.
Oh, yeah, but you're doing fantastic for being off drugs for so long, and still your PSA is so low. Very good.
Yeah.
Jeff Ledoux, did you want to say anything to George?
The only thing I've got to say is the Reader's Digest of my current situation. PSA's gone up a little bit more to 10.36 from 8 point something. Zytiga has not worked. And neither my oncologist nor I are very happy about that. We are going to try enzalutamide and see if that'll do anything. Still haven't done the ARV7 splice variant, but I don't think that's going to show us anything new.
Let's come
back. Agree with.
let's come
Excuse
back.
me?
We'll come back to you. We'll give you some time.
That'll be fine.
But
That'll
I'm
be
just
fine.
wondering,
I don't have anything that I can add to what George is
okay,
going through.
okay. Well,
Thanks.
George, look, I think that you can see that there's a lot of experience and some of it's pretty close to yours right now.
Yeah.
Um,
One thing I'm impressed with is, I've been a doctor for 20 years. You guys seem to have a better grasp on this disease than most medical oncologists, I got to say. And I've talked to a lot of oncologists through the years. So, that's
thanks.
you guys do your research.
We
That's good.
do, and one of the big benefits of this call is that we help people who come on the call to better navigate with their own docs, because there are things that we hear about, we research, we see, that we know may work for some men, and the doctors don't know about it. And if we can bring it to your attention and you can bring it to your own doc's attention, then it's all beneficial. Even if something comes, even though I appreciate it's not necessarily totally related to prostate cancer, if something comes of that folic acid, if it turns out you have that mutation, you heard it here. And that's really what this call is about. But what I really want to say to you is that we don't speak to you very often on the call, but I want to encourage you to keep coming back, because there are going to be other men who will be on this call at other times who will have other experiences that will also be pertinent to you. And
Yeah.
and I certainly encourage you to join that Inner Conversations call, because it's an experience just to listen to John Teisberg, isn't that true, Jake?
He's one of a kind for sure.
Yeah.
He's the one who created the group in the first place, and he is definitely one of a kind. He's got a very strange sense of humor. So you'll get a kick out of him.
Just
I do have a question.
Go ahead.
I'm struggling with going back to work. I've been on disability for 3 years now, and I went back to work a little bit after my first surgery, but I haven't been back since May of this year. And as I said, I'm an ER doc, so it's very physical. You're running around, you're doing this, that, doing procedures on people. Are you guys working? Do a lot of people go back to work with metastatic disease and the key? Everything seems to have fogged my mind, like my memory's gone, and
Right.
no, I don't know if it's the testosterone drop or what. But
So,
my cognitive function is not as it used to be.
So one thing I can tell you, I mean, I did 2.5 years of hormone therapy. You have to start using your mind. You've got to find a way to do it, because once you start, especially at your age, it will come back pretty quickly. So you've got to challenge yourself. I mean, this isn't work, for example, but I was playing a rubber bridge every night just because I wanted to force myself to use my memory. Now, I thought to myself, how the heck could I ever work again? How can I remember all this stuff? And yet, once I got into the swing of it, it took a few months, 3 or 4 months, but it came back quickly. Now, your situation is a very tricky one, because unless you're 100% present, it's dangerous. So maybe there are ways that you can work yourself back into doing what you do, or maybe you can find a different type of medical practice that you could do. But I would encourage you to put yourself in a position where you're using your mental acuity every day. Let me ask Larry Fish about that, because Larry's still working. Larry?
Yeah, I just unmuted. Yeah, I'm sitting here in my office right now. We have registration for the next cycle of classes in our program. My main function, besides sitting around, was writing the proposals, responding to the RFPs, the request for proposals. So it was like writing the competitive proposals and then managing the programs, getting them up and running. And that's really quite a mental challenge for me now. Now I work off of lists. I use my calendar basically to make notes for myself all day long because the the ADT does challenge you. And I also play Go. I don't know if you know the game Go. It's like chess or bridge. And I bought a computer software program, and every night I play a game against the program, and I challenge myself, play Scrabble with my girlfriend. So I try to like stay active mentally and stay active physically and put that balance together. Somehow I'm in pretty positive moods versus the terrible depression that I had originally. So I know that it may or may not work for you, but I know that there's hope out there.
Yeah, I've been a physician for so long that that's kind of like it's my identity, and I've kind of lost it. I don't even like think like I'm a physician anymore. And my wife wants me to get back to work. Like yesterday, she goes to work, and I sit around watching CNN all day and listening to Trump on tweet, and that's such a bad way to live your life. I'll tell you.
Yeah, I agree. I think you put yourself, not you put yourself, but one puts themselves in kind of a downward spiral and then it feeds on itself. And for some reason, I think you can get the spiral going the other way. I'm going to go to part-time soon because I'm going to be switching to the prednisone, or the Xtandi or the enzalutamide, Xtandi, because my PSA is starting to go, so I'm getting castrate resistant. So I'm going to go to part-time, but I set up like an office from the home so I can still work on half-time, and I don't know, I think it's good. I mean, I like to think like you probably have all this experience, this value sitting inside you for the field itself. You have all these years of experience, and now you stop running and you stop working, and then you get into this funk, and it's hard to push yourself out of it. But it really does. You really can. I find for some people I know or myself, you really can just force yourself to get up and start to function a little, and then it feeds on itself. And I hope that works for you. I hope you can find that and it works for you. I don't. Sounds like your job is physically stressful, so that's kind of a challenge, another challenge. But anyway, I find that it really does feed on itself, and a lot of, as Richard, all the guys are saying the same thing, most of them. So I want to encourage you as best I can.
Anybody else want to talk about work situation and treatment?
I think it's difficult. When I was on ADT, well, first of all, when I was diagnosed, I just retired from work. But if I hadn't retired, I'm not sure I could have done my job because I did have cognitive decline, in my opinion. And one of the reasons why I wanted to go on drug holiday was because I knew my cognition would improve, and it has. You have to be motivated to do what I'm about to say, but I took up learning a foreign language. Maybe that's very challenging for you mentally. If you had motivation to learn a foreign language, I would do that.
Good idea.
Of course, if you're not interested, that's a problem.
And one of the problems is, when you work in the medical field, and I might want to talk to that retired doctor a little bit. You go at it with a different attitude, which once you're the patient and you go in to treat another patient. When I went back to work, everybody had metastatic prostate cancer that I saw. Every patient. Now, of course, I've been treating patients for 20 years. That's not but when a patient came in with metastatic prostate cancer, it reminded me of my disease, and that's been the difficult. And like you said, I put myself in this situation, and I'm going to get out of it, because that's kind of what my personality is. I don't take no for an answer, and it's probably part of the acceptance of this being an incurable disease. I haven't accepted yet, unfortunately. I think I'd have more peace if I did, but I'm very stubborn, and being a physician, there's got to be something, right?
Well, Len's on this call right now. Len's the closest, because Len was a research pharmacologist and then a hospital pharmacologist. So he was working in the medical setting towards the end there, right, Len?
Yes, that's right. Now, I didn't know much about prostate cancer when I was first diagnosed. So when they told me I had this very aggressive prostate cancer, and it had gone beyond the capsule into lymph nodes and seminal vesicles and possibly bladder, I thought, okay, I probably have about 2 years to live. I've since learned that even the most dire original diagnoses, usually you can make it to 5 years with all the medications I have today. So that was why I retired, thinking, well, I don't have much time, so I don't want to spend that time working. But yeah, you really need to keep active. Don't sit and watch TV. Worst thing you could do.
Especially CNN. If you're going to watch the news, watch Fox.
Yeah.
Hey, this is a politics-free zone.
That's right.
Well,
we may mute you, Jake. Watch out.
Well, he said earlier he watches CNN most of the day. So
I heard what he said. I thought, oh, there's a good guy. I thought to
I won't say it again. I won't say it again.
Well, listen, with you being in Rhode Island, maybe you should learn Portuguese, right, Mr. Correa?
That's right.
So, which hospital, by the way? Well, let's find out if Dennis ever came into your hospital. Which hospital were you working at?
Well, there are two hospitals, Roger Williams and Landmark Medical Center.
No, neither one of those. I actually went to Roger Williams University, where I graduated.
Oh, okay.
Okay. All right. Well, look, we're going to move along, but hopefully you've gotten a lot out of this call, George. And we'd love to work with you closer and help you along. And I've got 3 contacts, so I'll be following up with you on those contacts for sure.
All right. Thank you very much, guys.
It's a pleasure. So, Jeff, I know you need some time. Jake, do you need any time today?
Well, I told you I didn't have my blood results back, but my wife brought it in while we were talking. So, but it's really non-eventful, so no.
Okay, well, we'll check in with you on what they are, because non-eventful is good.
Okay,
Larry,
yeah, right.
Larry, would you like any time?
No, I don't really need time for myself. I had an idea I wanted to float if we get 5 minutes near the end.
Super. Okay. Dennis, would you like some time?
Rick, no, I don't need any time. Thanks.
And Len, would you like some time?
Don't need it, Rick. Thank you.
Okay. So let's start off with Jeff Ledoux. Jeff, bring us up to speed. You mentioned quickly that your PSA is still heading the wrong way. I guess you must have had a meeting with Christian quite recently with Dr. Thomas. So tell us what's going on and what we might be able to suggest for you.
All right. We met last Wednesday, Christian and I.
Right.
He took one look at the PSA and he said, I don't like that. I said, I don't either. He said, it doesn't look like the Zytiga has helped. I've been on it for 3 months. and it hasn't worked at all. Hasn't brought anything down. He said, we'll try the enzalutamide, but that may not work either. And I floated the idea to him about Sam Denmead's ADT, bipolar
androgen therapy, BAT.
Right. And he looked at the article, because I pulled the article up and copied it. He looked at it. He said, so he's doing what? I said, as I understand it, he's giving large doses of testosterone along with the ADT that you stay on. He said, He said, I'm going to get a hold of him and see what we can do. Because now that I've failed abiraterone, that makes me potentially qualifying for his study. So that's where we are at the moment. I said, yeah, I wouldn't mind getting rid of some of my side effects. That'd be a good thing on the bipolar androgen therapy. He said, sounds interesting. So we're working on that. We'll try, he's going to do bone scan, CAT scan, the 15th of January, and we will review those results on the 17th. We've done bone scan, CAT scan before, and they've always come back no change, still fine. So I wouldn't be surprised to see the same thing again, but who knows? So that's where I am. I'm still conflicted.
So a couple of things. One is I would strongly suggest if Dr. Thomas is interested in this BAT, that he listens to the presentation Sam Denmead made to us earlier on in the year.
Yeah.
It's on the website. There's a page on the website. I think you know where it is. I see you're on the phone. So
I know how to get there, and I know where it is because I did listen to it.
Right. And I feel that the way that he made that presentation, it would not be too pedestrian for a medical professional. I mean, I know he was pitching it to us, but I think that it was sufficiently sophisticated that Dr. Thomas would get a lot out of it and understand a lot better what's behind that bipolar androgen therapy.
I will fax him that information.
Secondly, if he wants us to make an introduction, we would be happy to do it. Right now, Thibaut is just starting on his bone marrow infusions with Dr. Denmead. So, and he kind of sourced Thibaut through us in some ways, because Thibaut got more intrigued in the BAT, even though I think at the time he might have been seeing Antonarakis. But having said that, anything that we can do for you to make it easier for him to talk to Sam Denmead, I think we should do. The other thing that comes to mind is that, and I haven't read it yet, I saw it and I just haven't had a chance to read it, but the FDA is giving a priority review status to Apalutamide, which is ARN 509, ARN 509, Apalutamide, and that, if I'm not mistaken, is one of the drugs that is supposed to be effective if you are ARV7 positive and you have not responded to either Xtandi or abiraterone. So I don't know if it's available, how it's available, but it might be a drug. It's a Janssen drug. We have connections to Janssen, and if there is a way that that we can access that drug for you, we can certainly try if Dr. Thomas is interested. Now, I've posted in the chat window this new drug application for apalutamide, but I know that doesn't help you much. Are you on New Prostate Cancer Infolink? Do you see the stuff that comes through on New Prostate Cancer Infolink, Jeff?
Yes, I do, because Jan Manwright and Mike Scott have both been responding to what's been going on with me. I did want to mention one thing. I have been in touch with Kelly Franz at Johns Hopkins. She has forwarded all kinds of information to me, and I have filled out those forms, and I've gotten also the forms to Christian for him to fill out to set up for an appointment.
Okay, now
so we're moving quickly on this.
Did Mike or Jan talk to you about apalutamide?
No.
No. Well, Mike posted this on the 22nd of December. FDA gives priority review status to new drug application for apalutamide. So,
I can check that out.
So, he may not be aware that the apalutamide is supposedly targeted at men that are ARV7 positive. We don't know that you're ARV7 positive, but since you didn't respond in 30 days at all to the Zytiga, there's a possibility.
Yeah. And that's the other thing is that Christian and I have already talked about the potential for failure with enzalutamide, the way I failed so quickly with abiraterone.
Mm-hmm.
So, we're not holding out a great deal of hope on that, but this bipolar androgen therapy certainly is intriguing, to say the least.
Well, it is, but have him take a look at the ARN 509, the apalutamide, as well.
Okay.
Okay.
All right.
Let me open it up. Anybody want to say anything to Jeff?
Jeff, this is Len. Did you say you were on enzalutamide and then eventually became resistant?
Nope. On abiraterone, and apparently started out resistant to that. And didn't work with Casodex either.
All right, I'm not sure I heard you. So for enzalutamide, it was successful for a while, and then
no, have not tried it. That's going to come up next month.
Never tried it. Oh, okay.
No.
Well,
That'll come up next month.
I started Zytiga in January of this year, and the first 2 months, my PSA rose somewhat, not a lot, but somewhat. And my oncologist said, I have seen occasions where there's what he referred to as Zytiga flare. So early on, your PSA could actually go up, but then it starts to go down. And mine did go down in the 3rd month. So I wonder if maybe you could have given that a little longer trial.
I have not come off the abiraterone yet.
Oh, how many months are you?
I'm still on that, and it's been let's say October, November, December. So come up 3 months at January the 17th, and we'll see what happens there. In fact, I said to Christian that let's hold off on taking me off it for 1 more month because of the flare, and he did not hold out much hope for the flare to be active. But we'll see. We'll see in January. So yeah, we're looking at everything.
Len, do you recall how much your PSA went up? What it was when you started the Zytiga, and how high it got before it started coming down?
Yes.
Jeff,
you're talking to Len?
I'm asking Len for your benefit, Jeff.
Okay.
When I first started, my PSA was 0.11, And the first 2 months it rose to 0.17 and then 0.24, and then it started coming down.
Uh-huh. All right. Mine, when you started me on Zytiga, was 7.3. It went up to 8.4, and it's now at 10.36. So it's been a pretty constant. And the slope of that is pretty much the same for the 3 months.
Yes.
So I don't know. We'll see what happens.
Yeah.
I think it's, and I always, and this is just a gut. I don't know that there's any scientific backing to this, but I always feel that the way PSA moves when you're under 1 and you're looking at changes under 1 is not necessarily consistent with what happens when it's at a higher number.
Yeah.
You know, but you can't look at it. You can't look at the doubling the same way. And you can't look at the peaks and the nadirs the same way as you can once you get over, you know, into the sort of level where you are, Jeff. That's just my own opinion. Len?
Well, that's why we're
agree.
constantly looking at what's coming up next.
Right. Anyone else want to say anything to Jeff? Well,
I'll throw out one other thing. I talked with Christian about doing genetic testing. He said to do it on the old biopsy samples from 2014 would not give us a lot.
Agreed.
And he said to pull a bone sample, a bone met sample wouldn't do a lot either, because a lot of that gets lost in analysis. So we've got to find another way, probably liquid biopsy.
Okay, well, I'm not really sure what he's saying about the bone met. You just don't have a good biopsiable spot to take a bone met right now? Is that the problem?
He said the problem is when they dissolve out the bone, it destroys a lot of the tumor tissue, so that it doesn't get real effective.
Well, I think Foundation Medicine would beg to differ, as long as you've got a solid tumor. I mean, if you've got a good tumor that can be, if you've got a safe place where you can take a decent tumor sample, but Foundation Medicine can do a heck of a job on that.
Okay.
And
well, we can work with that too.
And again, if you'd like me to tie Dr. Thomas into the people at Foundation Med, I can definitely do that. The other thing is that you can certainly look at a liquid sample. There are not quite as many mutations that are identified on the liquid sample as there are on the bone sample. And unfortunately, there are 4 or 5 actionable genetic mutations that don't show up currently on the Foundation Medicine liquid sample, liquid analysis, but which they're actually talking about adding, but they may show up through Guardant or one of the others. You definitely have the option, and I think probably at this point it would be a really good idea to, as you know, we've often talked about it, but I think it really would be a good idea to do an analysis. Have you? I can't remember. Yeah, you've done your Provenge. You did do Provenge, right? Are you there? Jeff, did we lose you? I guess we did. I guess we did.
Oh, in progress.
Oh,
There. Am I back?
You're back. Yes.
Okay.
Have
I
you?
was trying to find Christian's number. I think it's 396. Oh,
Well,
the number escapes me.
yeah.
I'll get it to you. I'll just email it to you.
No, I don't need his number. He should call them. Better he should call them.
Okay.
And I will connect. But I will connect them if he wants to do that after you've spoken to him. Let me know, and I'll send an email of introduction, and then he can reach.
Okay.
Out. Or at that point, I can ask one of the people there to speak to him. But have you done Provenge yet?
Yes, I have.
That's what I thought.
I did that a year ago.
Right. That's what I see here. 714. Yeah.
Yep.
All right. Well, let's keep going. There's a couple of things here. Definitely some gene sequencing, some somatic testing would be good, and the apalutamide and the bipolar androgen therapy. All of those are out there, and maybe you'll get lucky, and maybe you will respond to the enzalutamide after you come up when you switch.
Okay. The one other thing I would mention is that today I went out and I snowblowed my driveway, did over 2 miles of walking, hauling my snowblower around, and I feel fine.
Good.
I don't feel sick.
Good. We're pleased.
So
we love to hear that. We love to hear that.
Well, I do too.
Good. All right. There was one other thing that went through my mind to mention to you. I forget what it was, but if it comes back to me, I'll raise it again. Jake.
Okay.
Tell us about these blood tests that just came through the door.
Okay. I've been on enzalutamide since 17 January. It brought it down from 15.7, and it went down. It fluctuated, but it's been down to 0.5 for the last 3 months now, and it stayed at 3.5 or 0.5. So it seems to be working fine for me, and I'm happy. Some people obviously have gotten less than 11 months out of it, but so far I'm doing well.
That's great. Congratulations, Jake.
That's great, Jake.
Thank you, Len. Thank you. I meant to say, Len, I like that halo effect. Is that the holiday season effect? You're trying to get
I do this deliberately so you all know that I am a saint.
It's very effective. It looks good.
Okay, thank you.
What about your other issues? How's your glucose, for example?
About the same, 108.
Okay.
That's about where it stays, and that's on the metformin.
Right.
Calcium, they show it as low, but it's not that low. It's 8.4, and that's without taking any extra vitamin D or anything. So
I did some metformin research this week because I have some really good friends, long-standing friends who are visiting Tucson for 3 weeks, and I had dinner with them on Saturday night, and we were talking about metformin, as old farts do, as you know. And David said to me, and he does not have prostate cancer, but he does have diabetes. And he said he's always very leery about metformin because of the cardiovascular issues associated with it. And I said, cardiovascular issues? I said, I've never heard. Oh yes, he said, if you know anything about metformin, you know there are cardiovascular issues. So I came home and I did some research, and what I found was that the original drug that preceded metformin, whose name I forget, something formin, I don't know, maybe Dr. George remembers what it's called, but I don't have it. there was a study done many years ago that showed an association between um, incidence of heart disease and this drug. And then subsequently, metformin got tainted with the same brush. But what they really figured out was that they weren't separating out the metformin or its predecessor from the effect of cardiovascular and heart disease for people that have diabetes. And
Right.
in fact, those people that were taking metformin actually had a lower incidence of heart disease and cardiovascular disease than
That makes sense. Yeah.
right than
Good.
if they had not been. And of course, my buddy, whose dad had also been on this drug, is convinced that it has an impact on his heart. And I said to him, you don't have to worry. In fact, the FDA removed its heart warning on metformin many years ago. So I just thought that was kind of an interesting anecdote, and how people sort of, it's hard to lose associations. So,
Well, thank you for getting my heart rate up when you said when you mentioned the heart issues.
okay, there you
Yeah.
go.
But now it's back down to normal again. Thank you for that.
Okay, good. So everything's solid and in place and steady and stable.
It seems to be. I mean, my numbers always vary. They fluctuate. Like my calcium's a little bit low, my protein's a little bit low. My AG ratio is a little bit high. But
What
it's never high enough to make. And my creatinine is low this time.
what's the AG ratio? Which one's that?
Um, Albumin and globulin, I think.
Uh-huh.
Is that right, George?
Yeah.
Okay. Even though my albumin and my globulin are both correct, or within range, the AG ratio is a little bit high.
Mm-hmm.
I don't know. She never seems to be concerned about any of these numbers.
Yeah, I think so often the numbers are guides, and unless you're well outside the range, they it doesn't seem to worry most doctors. Is that true, Dr. George?
Absolutely. You only need to know certain information.
Okay,
There's too much information out there.
okay. Um, all right. Well, listen. Stay with the course. Eat a little more of that wicked Christmas food, Jake. What did you
I
think?
didn't even. We didn't have it. We didn't have a Christmas dinner. I told you, my wife was sick, so she canceled dinner.
Right, but hadn't she bought everything?
Well, we didn't want her touching anything.
I know that,
she,
but now you
she
got
was
to eat.
contagious.
But you got all the food in your refrigerator. You still got.
Well, right. Yeah, we will. We will. She's going to make it, I guess, later on. My son's coming over tomorrow.
There you go.
Her brother and his family is coming over on Saturday. So
There you go. And
so
how much of that food that gets made is going to be really wicked?
well, it depends. I consider it good. So whether it's wicked or not, I don't care. Turkey stuffing, that kind of stuff.
Right. Just as long as you don't do any blood tests within about 4 or 5 days, you'll be fine.
Right. Don't do a lipid test. That's for sure.
That's right. That's right. Oh, so my lipid news is I can't wait. I'm switching from simvastatin to rosuvastatin on the 1st of January, or as soon as the drug comes through, so I can start eating grapefruits. Not only do I have that huge grapefruit tree I've told you about that's in my rental house up in Tucson, but there's a big grapefruit tree here in the garden, and it looks
Oh,
like
wow.
it's got lots of grapefruits on it. So I can't wait to start that rosuvastatin. It is now a tier 2 drug, because in the past it's been a tier 2 drug and it's been expensive, but it went generic last year, so it's become a tier 2 drug. So all of you who like your grapefruit and can't eat it right now, check out rosuvastatin, Crestor.
Well, good luck. I like grapefruit too. Enjoy it.
Okay.
I
Well,
think there's other medicines that I take that also say don't take grapefruit.
oh,
So
okay. All right. All right. Not so easy for you, Jake. So,
no.
okay. So, let's see. Larry, you got time?
Yeah, I'm here. Hello, am I back on? Yeah.
Yes.
Thanks. So I was just, this idea arose out of my last visit with Dr. Audio,
Mhm.
where we were talking about the clinical trials we were looking at because of the cost problems related to Zytiga or Xtandi, and we're looking at trials where we can do that plus some newer experiment. And we were looking at a couple of trials. My PSA hasn't gone up enough to get me in yet, and my A1C is still a little too high, but that's not the problem. The problem, there's not even a problem, that we didn't find an appropriate trial, and I asked her. I said, I've been looking at all of these trials myself, researching them, and I said, is there any point in me looking at clinicaltrials.org and following trials? Because you're so deep into the research and all this. And she said, oh no, definitely there is we work together on this, and maybe you'll find things that there are a lot of trials that I don't know are going on, or I don't follow what's going on around the country, around the world. And I started to think about our group and wondering the idea of if there was some kind of the idea of forming some kind of subcommittee
Mhm.
where 2 or 3 or 4 people might want to join a committee, especially if the group gets larger. And they could just like each week or each month, we could commit to spending an hour to look at some separately, and then to communicate with each other back and forth is like a clinical trial subcommittee, and just see what we would find in that hour that might be of interest, and mention it to ourselves, and then someone each week or each month could present this idea to people, um, instead of the idea of I thought about it selfishly, of myself doing this and then telling my doctor, asking her questions. I was thinking that it could be divided up between a few people if they were interested. And just this idea that could be some kind of a group that could commit to a little bit of time, not a lot. That was the whole idea I had, and just how I got to it.
I, I think it's a terrific idea. Let me throw it open to how other people respond, and let me kick off with Len.
Yeah, I also think it's a great idea. I'm not sure how you would envision it working. I think what we'd have to do is monitor clinicaltrials.gov for new prostate cancer clinical trials. And since there are probably an awful lot, I suppose we could divide it up by therapeutic modality, like chemotherapeutic drugs or immunotherapy or hormone drugs.
Yeah.
I think it's a great idea.
Yeah, sure. Whatever format, we could think of putting it together. But the idea would be sort of the 3 people or the 4, if other people wanted to join, there aren't that many, that they would communicate like outside a little bit, or maybe they would talk once a month, or before bringing it back to the group, and we decide like which ones we think we want to present, and then during the meeting, if there's enough time, we could take 10, 15 minutes and present the thing that came out of this committee. And just for people, and then people can go and look at it. And also the committee members, if somebody else has something interesting, they mention what they're looking at, everyone could take a look at it. And we get together some kind of consensus, then to come back once a month or every 2 weeks or even every week if we got so enthusiastic. I don't know how enthusiastic I'd be for that every week. That's the whole idea.
Yeah, well, I mean, we would definitely make time on the meetings for you. We would have to. I mean, I think part of committing to create a group like that is also committing to giving you time to share the results. Um, the question I have is, who would be interested in serving on the committees? I mean, I certainly would be interested in attending, but I don't want to commit to monitoring the trials because I've just got so much that I'm doing right now. So I would be maybe a quarter member, but we need people. I mean, what I would suggest is that, Larry, that maybe you would chair this effort, and then I don't know, Len, I don't want to commit you, but Len, you would be great on that.
Sure, I'd be interested.
And then we can open it up to. I'll start putting it in the letters that we send out and asking who would be interested and to contact me, and then I'll place them in touch with Len and Larry, and then however you wish to meet, and the meeting room is available to you. So, provided it's not at a time when we're otherwise using meetings and we can coordinate that, you can always come together and have a little meeting in the meeting room. So, that would work. And then you can share your screens and do all of that good stuff. So, I think it's a terrific idea, Larry. And thank you. I really thank you from the bottom of my heart, because I think it's going to benefit a lot of people if we start coming up with some good ideas on various trials.
Yeah, I mean, I don't know what we're going to come up with, but why not? I maybe in the letter. I mean, and I was thinking like committing to up to an hour a week among members, more or less. And if someone doesn't, they're busy, they don't, or they don't feel up to it. But just getting a few people to basically, buy into the idea. And then you could be CC'd. Everyone can be CC'd on the intercommunication. You can just follow along from the distance,
Right.
and just join in if you've got something to say.
Somebody wanted to come in. Who was that?
That was me, Rick. I just had a question. Are we limited to one number for GoToMeeting? The meeting ID that we use, is that specific to us?
Well, yes. The ID, that ID number is specific to using this room, but you could start another meeting at any time with a different room number, but you'd have to circulate that room number. So to make it easy, the other thing is we can only have one room open at a time.
Okay.
So even if we had two numbers, it wouldn't make a lot of difference because we can't use two different rooms at the same time.
Oh, okay. That's what I was getting at, because you mentioned the conflict of all the online meetings we have now. We're running out of calendar space, and I was thinking maybe we could run several simultaneously.
We can, but it will cost us more money. So it's something that we were looking at. We did not get the grant from Pfizer, although we'll probably submit again in the next cycle. And hopefully we're going to be doing more grant stuff going forward. It's something I've got to look at, and we'll gain more and more experience. But if we had a little money coming in, then yes, we would certainly look at putting ourselves in a place where we could run simultaneous meetings. I know that Rob's kind of interested in moving us to a different platform, but right now this is what we have. Is there? Well, Len and Larry, why don't you guys talk to each other? I'll make sure that you have each other's contact details, because I don't think you do right now. Is that right?
Yeah, I don't have Larry's
Yeah.
info.
And Larry, I'll make sure that you have each other's contact details. And then if there's anybody that you would like to see on this committee, let me know. Professor Bill comes to mind, and I don't know whether he would be willing to do it or not, but you could certainly call him up and pitch it to him.
Yeah, I don't necessarily have any desire to be the ringleader, other than the idea itself. Somebody could be or not, and the people I think should be honored are the people that are really interested in doing the
Right,
hour.
right, right, right.
We'll sift through what everybody says and decide like what way we decide what to present, or maybe there's nothing to present every week.
Well,
But what do you, yeah.
Larry, you know that that Len is a DOD. What do you call yourself? Researcher? What are you?
Uh,
Department of Defense?
no, it's called Consumer Reviewer for the Department of Defense. They have this program called Congressionally Directed Medical Research Program, where they invite patients with prostate cancer to participate along with scientific reviewers, on the evaluation of grant applications for prostate cancer research. And they meet once a year down in Reston, Virginia, right outside of Dulles. And it's always very interesting. But of course, it's mostly early research. It's preclinical. So, I mean, that doesn't apply to anything we can talk about here. But, you know, I'd be happy to talk with you offline, Larry, about how we could approach monitoring clinical trials that might be of interest. It could be pretty complicated because, you know, there's phase 1, phase 2, phase 3 trials. There's inclusion and exclusion criteria for every trial, but, you know, we'll sort it all out.
Yeah. Let's have a conversation and see if we can drum up some interest, and then I'll turn this whole project over to you with pleasure.
You know, I kind of feel you've used that line before, Mr. Fish.
Oh, right.
Merry Christmas, Len.
One thing
I would actually enjoy it.
One thing that you might, I'd ask you to consider as you're doing this is how we could put what you're doing on the website. So,
Yeah.
so that it could be recorded, and in some way we can create a page on the website, and we could put the information that you're uncovering directly onto our website. Because I think that would also be really helpful for a lot of people.
Yeah,
Yeah,
I agree.
I can picture that, you know, 80% of the stuff we look at may be phase 1 failing, or, you know, not interesting.
Right.
But as we go through it, we could put a list of what we're looking at, and then we could put a list at what we might be working towards selecting to present. Yeah, when we present, we can say we're going to talk about these 3 studies or these 2 studies or these 5 that we looked at.
Right.
And then, you know, when I go to see my doc, I can present her with any ideas. That's my selfish.
I think it's great, but no, but it's exactly what we were talking to George about at the beginning of the call. I mean, so much of what we do is helping men direct their doctors. I mean, look at, I think that Jeff Ledoux left us just before. But,
No, I'm back.
oh, he's back. Okay.
Yeah.
So you know, look at what Jeff's doing with Christian Thomas, and so much of what Jeff's doing is what he's learned from being on this call. And if you multiply that by all the people that are listening in and the number of people that we've helped to navigate their disease, it's really what these answer cancer calls are all about. At least the prostate calls, because my own personal opinion is that's where the way I wanted to shape them, to help men navigate their calls. Now, you know, it may be that the breast cancer call turns a different way. I don't know. It's going to be up to Helen and Tanya where they want to take that call, and you know, some of our other calls go in other directions. But yes, it's. Oh, Peter may be interested too. Peter, by the way, Len, Peter apologized. He's meeting with Helen. He's having lunch with Helen right now as we speak.
Oh, that's wonderful.
Yeah. So, but anyway, yeah, I think it's a great idea, and I would be happy to contribute whatever I can, and you know, let's try and make it happen, you know, during the first quarter of the coming year. It would be wonderful. It would be wonderful
Rick,
for everybody. Yes.
Rick, I too would be interested in this ongoing research into
Okay.
what is out there for clinical trials. Let's face it, I'm needing as much help as I can get, and I get a lot of help off this call, but I would also be willing to contribute by doing
Fantastic.
some digging.
Thanks, Jeff. And of course, your background is as a researcher too, isn't it? What, remind us.
I'm a chemist, mainly, but I also did surgical physiology research, studying effects of blood volume on shock and septic shock,
Okay.
and what we could do about it in large animals,
Okay.
not human.
Oh, I was going to say len's a large animal.
Actually, my boss used some of what we learned in the operating room, and he was a surgeon.
I thought you were going to tell me he was a veterinarian. I'm trying to figure out where to take this.
No, he became ultimately the head of surgery at Exner Medical Foundation.
Okay.
So he was pretty high up there.
Well, thank you so much, Larry, for raising this. It's a wonderful idea, and it's something that we'll definitely pursue. And it looks like just on this call, and we don't even have a big call today. We've got 3 people that can work together, and you know, we'll continue to mention it, and then between you, you can decide how you want to work together, and I'd be happy to help with the coordination, the communication, and however else I can contribute.
I'd be happy to help out as well.
Oh,
I'd be
who was
happy to
that?
help out as well.
Oh, George.
George.
Oh, thank you,
Great.
George. Yeah, fantastic. I mean, you know, what I like is that so now we're looking at 4 people, all of whom have some sort of either medical or social work background, which is dynamite, just dynamite. Fantastic.
Okay.
But look, it's 5:57, so where I am, Mountain Time, Arizona time. Excuse me, Arizona time. So it's that witching hour, and I wish all of you a really happy and more important, a really healthy 2018. And you know, we've seen some pretty interesting stuff from a standpoint of prostate cancer this year. I mean, a year ago, I really was not too optimistic about every metastatic man being offered either chemotherapy or second line antiandrogens so early in the disease process. And now, 12 months later, it seems like a given that one of those 2, if not both, is going to be there. I certainly wasn't. I mean, we were well aware of genomic testing, somatic and germline, but I didn't think it would have moved as far as it's moved over the year. And I don't know what to expect from 2018. It would be nice to see some significant breakthroughs in the immunotherapy field, and it may well happen. But you know, the one thing that we can be thankful for, even though we're wrestling this insidious disease, is that it is such a widespread disease that it becomes a priority for a lot of research money, just like breast cancer, because the big drug companies, if they can make a breakthrough, can earn a lot of money out of a new prostate cancer treatments. And so it just keeps it moving forward. When you look at some of the other cancers that don't have the volume that we have, they just struggle to come out with new drugs. And so I'm really hopeful that for 2018 we will make as big a strides as we've made in 2017. And speaking of which, that means that our next meeting will be, I see it's on New Year's Day in the evening. The first is a Monday. Well, we'll have it. We'll see. We may get a bunch of hungover people. But we'll hold the meeting. Some of you may be watching ball games. That's okay. We forgive you. But unless I hear otherwise, we will move forward, and the next meeting will be on Monday, January the 1st. Okay.
Thank
Happy
you, Rick.
New Year, everybody.
Have a happy New
Thank
Year,
you, Rick.
Rick.
Happy New Year.
Bye.
Good luck to all of
Happy
you.
New Year, everyone.
Take care. Bye.
Care.
Bye-bye.
Good night.